heart, a big chunk of what I do with my patients. I mean, yeah, I get the whole, like, hey, how are you coming? But then I spend the most of the time doing what I just did with you guys, going over how are you taking your inhaler, are we doing it the right way, and how do we manage a flare-up, how do you follow your asthma plan. It's a big part of asthma management, chronic, long-term disease management, making sure that they have a better understanding of their disease process so they can manage it themselves. And especially training kids so that as they turn into adults, they know what they're doing as they become more independent. The treatment guidelines clearly say that it's an integral component of asthma management and it should be treated as such by healthcare providers like us. We should be teaching our patients as well as healthcare policies and reimbursements. Fortunately, reimbursement has been the biggest challenge. Certainly there's some states where you can bill specifically the code for self-management education and get reimbursed for it. Oklahoma's not one of those states, unfortunately. So whereas just like a diabetes educator, you would never dream of diagnosing someone with diabetes and then being like, okay, good luck with that. You're going to pick up a bunch of stuff at the pharmacy. Good luck, right? Most new diabetics spend time with a diabetes educator, and asthmatics really should have that opportunity as well. But until Medicaid generally sets the stage for other third-party payers is on board with reimbursing for that, it's hard to justify somebody sitting for the exam and spending the time. But certainly it's our responsibility to make sure that our patients get educated, so it's definitely a battle that we still fight on a regular basis. There is a code for education, whether or not somebody wants to pay for the code that you build. This becomes the other issue, but it's actually the same code that's used for diabetes education. It's just education for self-management codes. What we know about management of flare-ups is that home treatment is best, and if patients know how to recognize their symptoms early, using a written plan that they can refer to, usually those who have written plans have fewer ER visits and hospital stays. They can adjust their medicine appropriately and keep it from getting rapidly worse. Everybody should have a written asthma action plan. They should have access to their quick relief medicine, both their short-acting beta agonist and an oral steroid. I think some providers don't like their patients to have oral steroids on hand at home, but it certainly saves a lot of ER visits if they do. For a mild to moderate flare-up, they're going to increase their short-acting beta agonists. If they have oral steroids on hand at home, which I think they should, they can get those started. Doubling the dose of the inhaled steroid during a flare-up is not recommended. It used to be pretty common practice, but what we know about inhaled steroids is that they don't provide quick relief, so doubling them during an attack is really not effective and therefore clearly not recommended by the guidelines. During a severe attack, serial treatments, and you see this is what happens in the emergency room, but that step can be done at home. Serial albuterol treatments back to back to back. Every 20 minutes for a total of 3, and whether that's with their inhaler or with their holding chamber or with their nebulizer doesn't really matter. It just should be serial treatments and oral steroids and seeking care if they're not improving rapidly. Home management things that you should not recommend is drinking large volumes of water, be it hot or cold, and school nurses are notorious for this, I don't know why. Breathing warm or moist air, I mean certainly if it's croup, that's one thing, because the kid who has asthma, steaming out the shower is not going to fix that problem. Over-the-counter things like lots of cough and cold products, and FDA came out years ago and said under the age of 6, they don't recommend any over-the-counter cough and cold products, one just because they're not really tested on kids. We don't know how effective they are or how safe they are. Pursed-lipped breathing, we'll teach some breathing techniques. I mean, it may help them to stay calm, but it doesn't really improve their lung function or help them to breathe easier. So these are not recommended. Warning signs, all patients should be aware of the warning signs. If they're having so much trouble breathing that they cannot walk or they can't talk, or there's blueness to their lips or nails, and I tell them the pink part of your lips or nails, not out here. There's a lot of perioral cyanosis. It's really just not real cyanosis, but the pink part of their lips, pink part of their nails, always a reason to head to the emergency room or dial 911. An asthma action plan is a written plan that guides them through what do I do when I'm having a flare-up? What is my plan of action? A lot of times they're color-coded. Green being you're doing good, yellow you're having a little bit of trouble. In red, it's an emergency, there's something bad happening. But it gives them kind of some ownership over their disease to say, okay, I know what to do. I don't have to panic when this hits. I know what to do. There's lots of different examples of asthma action plans. If you Google asthma action plan, you'll find more examples than you care to have. The asthma guidelines have a pretty straightforward one. The American Lung Association, there's lots of it that can be amended. Most electronic medical record systems now will have an asthma action plan that you can use specific to your practice too. But it should include at least their demographic data, like their name, so it's theirs, their contact information for their provider, whether that's their primary care provider or their specialist, whoever is managing their asthma, list of their daily medicines, what they should be doing every day for control, if they do peak flow monitoring, their peak flow ranges, a list of symptoms in progressive severity, like things that you're watching for, rescue medicines, how to take those, how frequently they can take them, how many puffs, and then those danger signs as a warning to and when to head to the ER. And a lot of them have pictures, like this one up here has kind of some examples, so because not all of my patients can read, and not just because they're little, but some of my parents of my patients can't read, so having those pictures is sometimes really useful too. But like I said, there's lots of different examples. And essentially what the plan does is it gives them, and this is similar to the one that we use in our practice, your feel-good zone, I don't feel good zone, I feel awful zone, but doing well, not doing well, mild, doing well, mild attack, more severe kind of exacerbation. But it kind of walks them through, okay, first I do this, then I do this, then I go to the ER. First I do this, and oh wait, okay, now I'm better, and now I'm back up to this part. Okay, I don't have to go to the emergency room. It gives them kind of just a step-by-step. Adherence to the asthma plan really depends on the relationship that you have. That's what they say more than anything, that the number one thing is, one, that they're educated, that they understand why you recommended that medicine every day, and that they trust you, who prescribed it for them, that that is the appropriate treatment. So really, adherence is such a huge issue in any chronic disease, not just asthma, it's a huge issue with diabetes as well. But certainly that relationship and spending time to educate them sends the message to them that you care about them being able to manage their disease. And it's not just, you don't need to know about it, I'll take care of it, you call me if you have questions, but you need to know about it, this is your disease. You need to have a good understanding, have a plan, understand how the plan works, and you just call me if you need me, but I think you're going to do great following the plan yourself. So, questions on asthma action plans. Have any of you guys seen those at all? Oh my goodness. Okay, now you have. You've seen asthma plans. Asthma is a reporting diagnosis now for one of the quality measures for hospitals, and it's one that we selected for our hospital system. And so every patient every child that's admitted to Children's Hospital with the primary diagnosis of asthma has to leave with an asthma action plan. That one that I showed you is our hospital action plan. So we're really trying to set a good example and spread that through the community too. But really the asthma guidelines say anybody who has asthma should have a written asthma action plan. And I highly recommend you, the primary care, that you make an asthma action plan and individualize it to your patient and teach them, review it with them. Okay. All right, peak flow monitoring is one way to measure, way to measure one piece of lung function at home. It's really no better than monitoring symptoms, and the guidelines really say that. If you have an asthma action plan based on symptoms, that's just as effective as an asthma action plan that has peak flow readings. Still, a lot of folks like to use them. We don't much because it's just one more piece of equipment that patients have a tendency to lose and struggle with. If we teach them the symptoms and they can recognize their symptoms, that's usually pretty effective. However, there's some patients that are really poor perceivers. They don't notice their symptoms. They may come in and say, yeah, I feel just fine, and they blow and their lung function is terrible. Those are really good patients. Those who were not really sick, like one day they're fine and the next day they're in the ICU being intubated, there wasn't a big warning. So for some of those kind of patients, the peak flow monitoring is helpful, and I listed those. Poor perceivers, those with severe history of severe exacerbations, and then more moderate or severe persistent asthma. Certainly it's not for everyone. It's one more thing to ask them to do, and if they don't know how to do it, they're probably not going to do it well. And it requires pretty good effort, so little bitty ones won't do peak flow monitoring well either. The best way to know what their peak flow is to monitor it over a period of a couple of weeks when their asthma is doing well, to determine what their best peak flow is, and then you can calculate their zones based on that, based on what their best was, and then 80% is their, and better is their green zone, 50 to 80% is their yellow zone, and less than 50% of their very best peak flow is that red zone. So then you can add that into their asthma action plan, so they have that objective measurement. Peak flow is, like I said, certainly not recommended for everybody, but it is one way to measure one piece of your lung function at home for just the right kind of patients. It's done very similarly to spirometry in that it's a forced exhalation, and what peak flow is a peak expiratory flow rate, so it's measuring the fastest rate at which air was leaving your mouth. So they're little handheld devices. They all look a little bit different. There's some pictures of some in the slide set, but essentially there's some kind of indicator that you slide down to the bottom, depending on which kind you have, and then it's you stand up, big deep breath, wrap your lips around it, and blast your air out as hard and fast as you can. And that little indicator valve will go up, and you go, oh, that was okay, 225. You bring it back down. You always do 3 efforts, and you write down the highest of the 3 efforts, and you get kind of a consistency there. And when you're monitoring it for the purpose of determining what's their personal best, you monitor it twice a day for a couple of weeks, just to get an idea of, okay, the very highest it was, and my very best day was 500, and so then I can calculate their ranges from that. There's a lot of potential for incorrect readings. It's a little one and they just go, I don't want to go to school today. Oh, that was terrible. That's in your red zone. We need to go to the hospital. So the same reason that spirometry, which you're going to find out as we go through the spirometry too, it requires really good technique for the person who's supervising it, who's teaching them how to do it, to make sure that you're getting good efforts. So that's certainly one. It's very effort dependent, and without a good coach or someone who can identify that, sometimes it can be a little bit tricky. But essentially a good effort would be down, take a deep breath, blow it right off the scale because it's a pediatric one. 75, then we do it again. I'm in good shape today, folks. So they do 3 efforts, they write down the highest of the 3. Okay. And there's good handouts within the guidelines on how to use your peak flow meter, and that's something that you can just print off straight from the guidelines. How to use your peak flow meter and the peak flow charts and that kind of stuff. It's all in the guidelines too. So the other way to be monitored is just clinical follow-up. Regular follow-up visits to reassess. And if you're considering a step down in therapy, certainly a close follow-up after you've stepped down is important too. So our goals with asthma management is to have happy, healthy kids and grown-ups for that matter, whose asthma does not limit them. I hate hearing, you can't play soccer because of asthma. It's just not the case. We can't do this. He doesn't ever sleep at night. Those are all just signs that somebody's asthma is just not under good control, and we need to be more aggressive with their treatment. The very first page in my little asthma education book that I do with them, it says, but I have asthma, can I do that? And the answer is yes, I can. I can play basketball, I can run track, I can go to the park, I can be involved in scouts. Those are all things that we really want. A well-controlled asthmatic, a well-controlled kiddo should be able to play and exercise without problems. They should be able to sleep well through the night. They shouldn't be missing school because of asthma. They shouldn't be missing work because of asthma. No hospital stays, no emergency visits, and no side effects from their medicines. So we really look at those as big goals, and we really want the family to be happy with the care that they're getting too, the control. This is just one example of education tool that I use, and this one I like because it walks through the goals of asthma therapy, simple pathophysiology. It talks about the different steps, mild, moderate, severe, persistent asthma, and are you well-controlled, not well-controlled, poorly controlled. It talks about asthma flare-ups, it talks about asthma triggers, specifics like having allergy testing done and all that information. It talks about the different kinds of medicines, controller medicines. Quick Reliever even has a place that I can write in there. They have their own book that they go home with. I write down, this is your controller, this is your reliever, tips about medicines, how to use your medicines. It even has a little example, and I can go through them and circle, these are your medicines, this is what yours look like. How to use your inhaler and spacer, how to use your nebulizer, how to do spirometry and what does that mean, and then what is an asthma action plan, and then they get their own. This one is available free for download, and I think still the best, and I have it listed in the resources there too, as the family asthma guide from the Children's Health Fund, and I find that one to be, it's also available in Spanish, that's the other reason why I really like that one. So I go through the color version, and they get a black and white cheap copy to go home with them. So having those other little tools, especially when you're teaching kids, hands-on, knowing their developmental level and what kind of learners they are is helpful. Be able to let them have some hands-on time, all kinds of little gadgetry that you can say, this is your lungs, this is what's happening in your airways, is all really, really helpful. So those are all my little asthma models. Only some of them live with me, some of them are just patients. So, okay. There's a lot of other references on here as far as reference support groups for families and that kind of thing. Before we start on spirometry, any big, burning asthma questions? Nope. Okay, you guys have already had, I understand, Andy told me that you guys have had some changes. She told me you guys had had a little bit of exposure to spirometry in another lecture. Yes, and it's all clear as mud. That's what she told me. Is that true? Yeah, it's pretty clear as mud. Okay, I'm going to try to make it so just the spirometry piece of it as easy as possible, okay? Spirometry is just one piece of pulmonary function testing, right? But this is what you're going to see most often, especially in a primary care setting when you're looking at, or even if you're sending them to the specialist and it's coming back. And spirometry is what we use for asthma care. So I'm going to try to make this as straightforward. Step 1, you look at this number. Step 2, you look at this number. Step 3, you look at this number. It's pretty easy. Okay. It's not quite as easy as these little charts for asthma, but it's pretty easy. And I'm going to have some examples for you guys at the end so we can practice with a view and implementation. Okay? So we're going to identify the role of spirometry, demonstrate the technique, look at a report, distinguishing a restrictive pattern and obstructive pattern, and the severity of obstruction. Again, a ton of abbreviations. I apologize. It's just the nature of the beast. And there's a lot. So historically, it amazes me that folks in the 1840s were trying to figure out ways to measure lung function, and the way they did it was really super cool. So there's been a lot, I think there's some really cool designs for how they've done it over the years, and I'm not going to bore you with the history of it, but one, we've been measuring lung function for a long time. The ATS standards were really set in the late 70s, and that's what we certainly have come a long way from the 1854 to, that's actually a picture in our spirometry lab now, and certainly technology has advanced away. This one I saw on this, she sent me actually slides of what you guys have already seen. So very, very simply, tidal volume is just what you're breathing normally, right? That tidal volume, right? And this looks at then when you're doing spirometry, they do tidal breaths first, and then you have them take a big deep breath in all the way full. So that's full, like vital capacity, that VC, all the way up as full as you can go. And then you blast it out as long as you can until you're all the way empty. So that is then full volume. Does that make sense? So compared to like tidal, compared to full vital capacity. So this is showing, that's showing a breath. Somebody doing this, normal breathing, but not after that breath out. That would go down below the line. Does that make sense? So a spirometer measures the volume of air exhaled, inhaled and exhaled over time. And so you get a curve that's volume over time. There's lots of different little handheld ones. The lecture that you had, did somebody have a spirometer with you? You were just looking at the values and stuff. Okay. So there's lots of different ones, little bitty ones that you can hold like this, little handheld ones. And in primary care practices, this is most of the time what you're going to see. That big box that you saw there that we have, certainly we measure a lot more than just spirometry. We do full lung volumes and that kind of thing. So that large of a device is really only like in a pulmonary function lab. But what's used in primary care just for spirometry is usually one of these little ones. And they're really pretty easy to use. The little screen kind of walks you through entering the patient's information. You have to have that because the normal values for spirometry is based on your age, your gender, your height. So there's normal values that are pulled from it. So you have to know how old you are, male or female, height, and then some actual predicted sets correct for race as well. So certain races have higher lung function than others. So the indications, and that's a long, long list. So there's lots of reasons why folks may do spirometry. My main reason is one is doing as an assessment for asthma and monitoring for asthma. But certainly if you're looking at public health issues, they may measure lung function after exposure to things. They're concerned about public health issues. There certainly can be a lot of others. Pretty much have to get spirometry done if you want to go into the military, I'm quite certain, and other things. It's just as an overall health assessment to be sure there's not any kind of dysfunction there. So there's a lot of different reasons to do spirometry. But as far as primary care goes, the main reason is you're looking at objective measurement of airflow obstruction. We said that in order to diagnose asthma, you have to determine there's airflow obstruction and that it's at least partially reversible. So these are two things that you can do with spirometry. It gives you an objective measure and allows you to assess them and then monitor after the fact. And both the diagnosis and measure. Just assessing to see, is my treatment plan working? Is how's their lung function working? And this is specific straight out of the guidelines. We already talked about it, so I'm skipping. Spirometry definitely is part of the asthma diagnosis. So according to the asthma guidelines, spirometry should be done at the time of initial assessment when you're first diagnosing them. After treatment is initiated to be sure that you know that they're well controlled on that treatment plan. Anytime that they're out of control, if you've just stopped their medicine, spirometry after you've stopped their medicine, after a period of a couple of weeks after you've stopped or a month after you've stopped, is a good way to know that I stopped the medicine, they're not symptomatic and their lung function is still normal, so we're still well controlled despite having stopped it. And then at least every 1 to 2 years to assess maintenance. We check it every time, so every time we see our patients, we do spirometry, but we have the luxury of having a PFT lab there in our clinic. But certainly your asthma patients and the outpatient primary care should have lung function measured at least every 1 to 2 years. This slide I skipped past last time in the asthma lecture because we're going to talk about it here. We need to know, is there obstruction, and then is it at least partially reversible? So for obstruction, one way to know that is the FEV1, which is forced expiratory volume in the first second, how much they blew out in that first second, is less than 80% predicted. Or if the ratio between the FEV1, how much they blew out in the first second, and how much they blew out total forced vital capacity, if that is below the lower limit of normal compared to their own predicted value for their age, gender, height. So that's obstruction. And then for reversibility, did the FEV1 go up 12% or more or not? Essentially 200 milliliters and 12%. And sometimes, and that's usually just after a bronchodilator, like a few puffs of albuterol, but sometimes if they're really, really in bad shape, if we're talking about one of these people where their airway, looks like this, they may need a week or so of oral steroids. They may need that 3 to 10 day burst of steroids in order for you to see that reversibility and you bring them back, and now their lung function is much better. So that's reversibility. 12% change, 200 milliliters. And that certainly can be done either with a bronchodilator or with a steroid. Okay? So it's the gold standard for asthma, generally useful over the age of 5. Some kids can't do it really well until they're closer to 7 or 8, but we usually start practicing when they're 5. It doesn't do you a whole lot of good to refer a 3-year-old to the PFT lab because what we're going to send back is, they really can't do it well. So we can't give you any good information about that. It's probably fun for them, but it's not going to give you useful information. Preparing them beforehand, it's painless. They're just going to blow. And I tell the kids, you're going to blow in the machine, you're going to play a game. It doesn't really hurt. It's not super easy to keep going. If your asthma's under good control, if your asthma's out of control, you have a whole bunch of air trapping and somebody says, keep blowing, you've got all kinds of air and you can blow and it's really easy. So it kind of just depends on how well controlled you are. But essentially, you're going to tell them they're going to breathe in, they're going to blow out into the machine. And there's some little incentive spirometry that's helpful. Really requires a very skilled technician that's doing it, somebody who does it on a regular basis. I tell people, if you have one of those little handheld spirometers and somebody says, we have spirometry here, yeah, it seems like there's something, let's dig it out, let's dust it off, I wonder if we can do that. Would that be, if that's the experience, I wouldn't necessarily trust the data that you get. If the person who's doing it is like, I feel like I learned about this a year ago or something, probably you're not going to get a really accurate result. In that case, just refer them to a PFT lab. And most larger centers are going to have a PFT lab. They don't have to be seen by the pulmonologist, but just go to the PFT lab and have them done. And then all the equipment should meet the ATS standards, and like I said, those were set like in the late 70s when they set standards for spirometry. You've got to calibrate the machine, and we have like a little 3-liter syringe that we tell the machine regularly, this is how much is 3 liters, and it gets checked really regularly according to the guidelines from the ATS to make sure that you're getting an accurate reading. And then the technician is responsible for watching their technique, looking at the values to be sure that they match one another, and that's called reproducibility, as long as those efforts are within a certain amount of one another. And most of the digital programs will tell you that immediately, like this effort was far different than the others, so it's not accurate. And the nice thing is that the software does a lot of that work for you too. But it's good to have a good technician. It's ideally performed standing with a nose clip, but that's not an absolute. It just should be consistent. If they're in a wheelchair and they're always seated for it, it should always be done seated because you want it to be a consistent pattern. They're going to get maximal forced exhalation. You're going to assess to see is it an acceptable effort and is it reproducible before you're able to interpret it. Coaching them is a big part of it. If you don't look like a complete goof, if you're coaching someone, you're not doing it right. Especially in a pediatric lab, you definitely look like a goofball. So this is essentially kind of an example of what it looks like when they're doing spirometry. You're doing that normal tidal breath, big deep breath in all the way in, and then blast of air out, big blast of air out, and then you go and you go and you go until you're all the way empty. You need a 6-second blow for it to be sufficient. If they have a bunch of lung, like I said, if they have a bunch of trapped air, they can probably blow for a lot longer than that. And like I said, the software will generally tell you, usually you get a little green light to say, okay, you did it, you're done. This is an example of the loop and the flow over time. So you've got the top bar is your flow over time. And if you're looking at that and the loop looks very jagged, they probably coughed, and that is an example of cough on that picture. But you want to make sure for it to be acceptable that there's not a whole lot of that going on. So unfortunately when somebody's really sick, sometimes it's hard to get a good measure of their lung function if they're coughing a lot during the episode, or if they close off, they get glottic closure early, if there's some kind of equipment problem. You want to make sure they got a good start, and so having a good technician to tell you, and they'll put a little note on it for you that they got a good effort. But 3 acceptable spirograms. The 2 largest FVCs should be within 200 milliliters of each other to know that that was a good, consistent effort. And these are some examples of what would be considered good and what are kind of poor efforts to start. One's not full at start and one they closed off a little bit too early. And if I had a pointer that could point, I'd tell you what I meant, but I don't know if you guys care. It's late. So there's one example with a cough, and then the other one is that's probably a little kid just playing around. He blew out and up and down and all over the place. And he probably had a really good time, but that would not be interpretable at all. That was just a real varied effort. The other one was pretty clearly coughing and does look obstructed, you can tell just by the shape. And so that's looking at lots of different curves and examples of what some of the shapes of the different curves look like. And varied shapes based on the volume, the amount of effort given there too. So after 3 acceptable spirograms, where they've actually done 3 that are consistent, they did a good job, they blew long enough, they're within the right volume of one another. Or if you've done 8, then you just stop. That's generally what they recommend. If you've done 8 and you haven't gotten 3 that matched, this is somebody who probably just isn't going to get you're not going to be able to get an accurate reading. Or certainly if they're having such respiratory distress that they can't continue, then certainly they should stop. This shows the loop and what kind of each point on the loop represents. So they're the flow over time, volume over time. And the forced vital capacity is the maximum amount, so the total amount that you blew out. FEV1 first, the amount you blew out in the first second, The FEV1 to FVC is the ratio between those two, and that's expressed as a percentage too. And then the peak flow is one thing that is measured as well, and it's the same as what was measured on the little handheld peak flow meter. Caveat is that this is measured in liters per minute compared to liters per second. So when you're comparing what they did here compared to what they did there, you have to make the conversion from minutes to seconds. So I mentioned already that their predicted amount, it depends on how tall they are, how old they are, what their gender is. And you get a percent of predicted. So the number that you hear people talk about, and like what you're looking at the guidelines, when it says, 80% or better, that's the percent of the predicted amount. So if they blew exactly what was predicted, that would be 100%. 100% would be blew exactly what we predicted that you would for your age, gender, height. 80 to 100 though, 120 could really be normal because everybody's not perfectly average. Some people a little below average, some people a little above average. 180 to 120 is really considered normal. But what's more important is what's normal for that patient once you know them. And if you know their baseline is 98% of the predicted amount and they come in and they blow an 80, although 80 is not too bad maybe for somebody else, for them, we know they're capable of closer to 100, so we know that they're down for them. All right, so when you're interpreting, you're looking at both the absolute amount, but more so at that percent of predicted. So for FVC and FEV1, if it's about 80% of predicted, it's within the normal range, and the ratio is at least 80% of their vital capacity in 1 second. So if the ratio declines as a normal part of aging, so that's why on the guidelines where it had that little breakdown of what the normal ratio would be, it kind of breaks it down on that part of the guidelines as far as based on your age, just naturally will decline over time. You guys went through this FVC stuff before, that sounds familiar? You feel good about that? Okay. These are examples of reasons that your forced vital capacity would be decreased. With asthma, would you expect the forced vital capacity to be decreased, or would you expect it to be normal? Is there a volume problem? No, there's not a volume problem, right? So we would expect the FVC to be normal with asthma, right? Times that it might not be, someone who's pregnant. When you're pregnant, you get some restriction. Someone with neuromuscular weakness may have restriction, may have issue with the volume. Certainly if you've had lung resected, you have a change in volume, issues with muscle, and I kind of highlighted some of those sort of key things there. So as far as the amount in the first second, it is the FEV1 is the most reproducible thing, and you hear that discussed most often when it comes to asthma. The FEV1 is what you hear the most. Most commonly measured and easiest to get reproducible data on. And the ratio between the two is generally expressed as a percentage. It declines with age, we discussed that. Children have higher flows for their size, so their ratios are higher, even up to 90. So I have to look at not just is your ratio over 80, but is it I actually look at what the predicted should be for their age when we're dealing with littler kiddos, because we expect them just because of their size that their ratio should be a little higher. So the significance of this ratio is twofold. It aids in quickly identifying people with airway obstruction in whom the FVC is reduced. For example, if the FEV1 to FVC is very low at 43, the low FVC is due to obstruction, because we know that if the ratio between the two is low, it must be the reason that total amount is because of obstruction and not because of restriction. The second, the ratio is valuable for identifying the cause of the low FEV1. In restrictive disease, both the FEV1 and the FVC are decreased proportionately. So the ratio is normal, but in obstruction, you're going to see that the ratio is decreased. So obstructive defect implies that something is that causes a decrease in the maximal expiratory flow, so that rapid emptying of the lung is not possible. And it makes complete sense that when your airway looks like this, it would be difficult for you to rapidly empty your lungs, right? So that's an obstructive problem. And not only asthma, I mean certainly CF can cause obstructive lung disease. They've got infection, all kinds of other things going on, but certainly obstructive defect. Restrictive implies that the lung volume is reduced by one of the other processes, okay? So to be certain that a restrictive process is present, the total lung capacity must be less than normal. So if you've done just spirometry, You can suspect it's a restrictive pattern, but then you need the lung volumes, the full test where they get in the box and they do the whole thing, which we're not going to talk about today. But that is a much more sophisticated test where you're actually measuring total volumes. So reduced, so here's the straightforward. Reduced ratio of FEV1 to FVC as compared to the predicted indicates obstruction to the flow of air from the lungs. A reduced FVC with a normal ratio is restriction. That's probably the most straightforward way to say it. If the ratio is low, you're dealing with obstruction. If the ratio is normal and the FVC is reduced, you're dealing with restriction. Okay? And that's exactly what that says. So we'll skip past it. Now this is looking at the loop itself. The dotted line is kind of what you would expect to see, normal, and the blue is what this patient blew. And just looking at it, you see that it has a kind of a concave shape. It's taken on a scooped out appearance, which is obstruction. When you see a scooped appearance, you know it's obstructed because it doesn't have that gradual return. It goes out like this, and that air that's trapped out there, they keep going right there, almost empty, keep going. Makes sense? And there's a normal, an obstructive, and a restrictive pattern. And that's not perfectly normal, but as normal as I can find it from RPFT Lab. Obstructive, and you can see that. And then restrictive, on the other hand, it has the normal shape, it's just a lot smaller. So just glancing at that, it's pretty easy to see that that obstructive one has that scooped out appearance, goes forever, and that the restrictive is just a lot smaller. So there's an example with the actual values there. One, just looking at the loop, you can see that it's scooped out, so that suggests to you that it's obstructed. But when you look at the ratio, and that's always what you want to look at first, the measured was 48, the predicted was 68, so it was low. And then the FEV1 was also 68% of predicted, which is low, but the FVC, the forced vital capacity, was normal. So this would be considered obstructive, clearly, right? Is this a little easier? Okay. Try not to get too many other numbers involved if it's too complicated. So there we have it, a ratio that's reduced, an FEV1 that is reduced, a normal FVC, obstructive pattern, and that scoop is pretty classic for that. So a restrictive pattern would have a low FVC and FEV1, but they're proportionately low, so it makes the ratio, the measure there is 98% on the ratio, so normal ratio, so that's a restrictive pattern. And there's a picture of that. So for example, this could be like maybe a kiddo that we see with Duchenne's muscular dystrophy. That's one example. Okay? So calculating the percent of predicted, really not necessary because the machine really does all of that for you. But essentially you're looking at what's the predicted amount, what do they do? And do that. Establishing reversibility, so you're looking for what percent of change for reversibility? 12%, that's the right answer. And how many milliliters? At least 200 milliliters, right? In a short course, sometimes it's required. Degree of reversibility generally declines with long-term control. So if I see somebody who's well controlled, do I expect them to have a 12% reversibility? No, because I've gotten them to their best, and if they came in and they blew 98% and they blow 98%, it doesn't mean that they don't have asthma, they don't have reversibility. It's because they're already at their best. So this has the calculations for change in FEV1 when you're looking at reversibility. That is a 20% improvement, which is significant. To say that is, does that meet the criteria of 12%? Absolutely it does. That makes it easy. If you walk in the room, before you even walk in the room, you see a 20% reversibility and you go, well, I don't know what you have. I don't even have to ask you any questions. That's helpful. So this is just asking you to do the math, which it's too late on Friday to do math. Then that one is an example looking at making sure that you have the difference in the volume, actual volume difference. Okay. So this is an approach, and this is based on an article that I cited in there. That article, I think, is one of the most straightforward articles for interpreting spirometry, just offering this like organized approach. So one, you look at their demographics. It never fails. A couple times a year, I will have a kiddo that is marked as a male, even though it's a female, and that totally messes everything up. Like all of a sudden, I'm like, why is the lung function bad? Like somebody clicked the wrong box. So one, you want to make sure their height, their gender, their age is correct, because that very, very much affects their predicted amount. Was the test acceptable and reproducible? Did the loops look like they were just playing around in there, or did you actually get nice, good ones? And did whoever was doing the test, the respiratory therapist or the pulmonary function technician, say that they had reproducible efforts within a certain amount? So you want to look at that, and they'll usually comment to that. Look at the appearance of the curve, and usually that tells you a lot. If you see a big scoop, you know without even looking at the numbers that it's kind of obstructed. And then you look at the ratio. You look at the ratio first. A low value indicates an obstructed pattern. Then you just need to quantify how obstructed is it and assess for reversibility. So ratio first, and then quantify how obstructed. So yes, it's low. How low is it? Is it mild, moderate, or severe? And then assess reversibility. And then a normal value in the ratio indicates it's either a restrictive pattern or it's just normal spirometry. So if the ratio is normal and the FVC is low, it's restrictive, right? But if the ratio is normal and the FVC is normal, it's just normal, and that's a good day. Normal spirometry, that's easy to interpret. This has a breakdown of just that, walking through it, and I think this is a really good step-by-step walking through it from that same article. This is just, if you're more of a chart person than a paragraph person, there's another way to look at it. And when you're looking at how obstructed is it, then you want to say, is it mild, moderate, or severe obstruction? Here's where it gets really confusing. Mild, moderate, and severe obstruction is not the same as mild, moderate, and severe persistent asthma. The numbers don't match up perfectly. So mild, you just have to trust me. When you look at the chart, it may be like this one is, 80% of predicted, and here is 68. So it doesn't always correlate exactly like that when you're interpreting spirometry, that moderate obstruction correlates directly to moderate persistent asthma. It would be easy if that was the case, but it's just. So obstructed pattern with an FEV1 greater than or equal to 60 is mild airway obstruction. So if their ratio is low, and you look at their FEV1, and it's 89%, that's mild. Their FEV1 is really normal, right? It's pretty good, but the ratio is decreased, so you know there's obstruction, but it's mild obstruction. FEV1 between 40 and 60 is moderate obstruction, and an FEV1 less than 40 is severe obstruction. So if you look at the ratio and it's low, and then you look at the FEV1 and it's 45, that's moderate airway obstruction. Make sense? 35, severe. Easy, right? And I put the little note there. That doesn't directly correlate with mild, moderate, and severe asthma categories. But it does have a little discussion there of, this is where spirometry fits into the guidelines, that big chart that I showed you with all the things, that's where the lung function fits in. Looking at FEV1, the ratio, and all that. And you can see there that an FEV1 of less than 60 would put you into the severe persistent category. But that doesn't mean, just because it's 55 doesn't mean that it's severe airway obstruction. It's still moderate airway obstruction. Does that make sense? Sort of, a little bit. Okay, so we're going to practice. Your choices are a normal, we're going to look at some. Your choices are, this is a normal spirometry. It's a restrictive pattern, which means they would need additional testing. Clearly, it's not asthma. We need to test for, we need to look at the lung volumes to confirm. A mild obstructive pattern, a moderate obstructive pattern, a severe obstructive pattern, and whether, if they are obstructed, is there significant reversibility or not? Or my favorite answer, uninterpretable. They just couldn't do the test. They didn't do it. They weren't acceptable efforts. They weren't reproducible. We can't interpret it. And in pediatrics, unfortunately, that's the answer a lot of the time. So sometimes we give our best interpretation. For example, if somebody gives a terrible effort and their loops all over the place, but their numbers are pretty normal, it's hard to fake normal. It's hard, you can't really fake a good lung function. So we can say, although their effort was suboptimal, the values are good and normal, which is reassuring. However, if it's really low, it could be just because they went in there and they look really wimpy. Okay, so this is an example. It doesn't have the demographics on there, so you'll have to trust me that we checked the demographics. So if we're looking at the ratio, and on this one, is our report, it's the third one down. The reference is the furthest on the left, and then the predicted, and the percent of predicted, and then that's a pre and a post. So there's kind of three columns there, the reference, the pre-test, that's before albuterol, and the post-test. So what we see on this one, on the pre-test, the ratio was 43, low, very low. It should be greater than 80, for sure, 87 in this case. And so we looked at, we know the ratio is low, which means it's an obstructive pattern. And so then we look at the FEV1 to say how obstructed. 36. Ooh, what do you, severe, right? So this is severe obstruction. Is there reversibility? It improved from 35 to 41, and it's tricky the way that ours is. If you follow that one where the 35 and 41 are all the way across there, the post percent change is 16. So yes, it didn't reverse as much as I'd like to see it reverse, and I wouldn't let anybody leave with lung function that low. They probably got admitted, is my guess, because that's pretty crummy. Now this one, and just the appearance of just look at the appearance of the loop on that one compared to this one. That's a pretty dramatic difference. That is very scooped down and a long, compared to this one, which is kind of nice and pretty and round, right? When you look at this one, there's no post-test on this one because they did so good to begin with. That's the reason why, and it's kind of hard to see from a distance, but the ratio on this one was 91. Normal ratio, normal FEV1, normal FVC, normal spirometry. And it's nice, our respirator gave us a little hint there that the spirometry data is acceptable and reproducible, and told us even what the patient did the last time we saw them, and they even beat their last score. So, very good. So pretty dramatic difference between, oh, that looks terrible, this patient needs to be admitted, and hey, that's pretty good, might be better than me. All right. So here we have ratio. Eyes are so bad. I'm going to turn this way and work with you guys. Okay, so our ratio on this one was 60. And our FEV1 was 49. So how would you classify that? Moderate with significant reversibility. Right? 23% change after albuterol. Right? Is this getting easier? Mm-hmm. Okay, good. What do you think of that one just glancing at the loop without reading what the respiratory therapist said? And they didn't do a fantastic job. I mean, it's nice and round, and it's pretty. Pretty good, but they didn't really do a great job, and we can tell because he says patient was unable to produce acceptable and reproducible data. Actually, she said that. And so, but if we looked at it, I would say, you know, even though they did kind of a crummy job, the ratio is normal and the FEV1 is normal, the FVC is low, probably just because they didn't do a great effort. So I would say, despite poor technique, really it's pretty reassuring. But technically, you can't really interpret that because they didn't do a great job. Easy? Yes, getting easier. Anybody feel bold about this one?
It's pretty good. I think it's restricted.
Yep. Pretty significantly so. Pretty significantly restricted. Yeah, I think this is a Duchenne's. And what I would tell you is I can tell, the reason I know it's for sure Duchenne's is because this is definitely a neuromuscular weakness kid because that post-test is not actually a post-bronchodilator. That, she says, represents peak cough flow. So on the second test, instead of giving albuterol and repeating it, we have them, they do spirometry first, and then we have them cough into the machine. And they cough into the machine so we can measure what their peak expiratory cough is to qualify them for a cough assist device. If it falls below 270, they really need help coughing. That's how weak they are. And that's really helpful to be able to get those kind of things approved. So excellent restrictive.
But good reversibility.
It's huge reversibility. Really, really big. probably a non-adherent, somebody who hadn't even taken any albuterol today, and we just gave them a measly 4 puffs, and they improved 79%. I feel better about sending them out because they improved so much. But they also, you can see there was a little bit of coughing, maybe a little bit of funniness around their throat as they were doing that. They had a little bit of trouble, so they probably weren't sick, that's my guess. And somebody, a baseline around 85, they can usually be 85, and today they came in at 36. I think I remember who that was. It's not good. All right, anybody feel strongly about this one? So the RT gave you a little bit of a hint. It didn't do perfect. There's a cough on there, and you can't tell on the, because this is black and white, but ours has a the pre is one color line, and the post-test is another color. So pre before albuterol, post-test after albuterol. And so you can't tell, but I think that was on the pre-test, I think there was a cough midway through. So that would technically disqualify. But despite the fact that the technique wasn't great, it was, you know, it was all right. In fact, better than last time we saw him. Last time the FEV1 was 79 and 88, so big reversibility last time, and this time better. So despite poor technique, appears normal. Yeah, and she even put on there difficulty due to cough. That one. Do what?
But the level seems 87, so that would be.
So the 87 is the reference. So the actual for the patient was 68. So the ratio's reduced. So there is obstruction, but it's real mild. Yeah. So there, ordinarily you look at that, oh, FEV1 of 90, that's really pretty good. The ratio's decreased, so there is obstruction, but it's really mild obstruction. And they're at their baseline. And really the loop doesn't look too bad. It's not as round and pretty, but it's not super scooped out. That is me, I think. That is me, yep. So I have a little hitch. They call this a knee. I don't know if you can see. As it goes down, it kind of does a, and I don't know if that's a little bit of a vocal cord issue that I have or what, but some of them will make that little, like, almost like a little hitch, like it's almost like the top leg and then the bottom part of the leg on the breath out. They call that a knee on there. I don't know why, but that's normal. I did my very best try. Okay, so discussing them with the patient. So is this helpful, guys?
Yes.
Much easier, straightforward, right? Now don't ask me all about VLCO and total lung volumes, because by golly, that's when I say, oh, it's not asthma. Good, I get to pass you on to somebody else. So discussing the results with the patient, just acknowledge that this is one piece that combined with their history and their other things, you know, can help us to confirm it. Spirometry all by itself doesn't make a diagnosis. Although when you see a 20% reversibility, pretty convinced. Sometimes we need more tests. Connecting the spirometry to the bigger picture helps them with adherence a lot of times. If they come in and they say, yeah, I haven't really been taking my medicine like I'm supposed to, and they blow 70-something to begin with, and their baseline is closer to 90 after a few puffs of albuterol, they come up to 90, you go, see, look how much potential your lungs have. And if you would take your daily medicine, I bet you would blow 90 to begin with, and then you convince them to do it for the next month, come back and blow a machine, and sure enough, they do. And that lasts for a while, and then a couple years go by and they get lax again, and you're like, remember back when? And we go back and look at your PFTs, remember when this happened and I convinced you and it worked? So it really is pretty helpful to have an objective thing, because when everybody's interpretation in their mind is different, but the numbers help. Sometimes they don't lie. You say, I feel pretty good. Well, okay, well, your lungs don't feel as good as you. They only feel about 70% of what they should feel. So there's the references. That article, recognize the pattern and the diagnosis will follow, that one from the Cleveland Clinic Journal. That's the one that has that chart in it, and it has the first look at this, then look at this, then do that. It makes it very straightforward and easy. I think straightforward and easy. So thoughts? I know it's the end of a long 3 hours of listening to me talk. Very long time. So I have a lot of other devices and stuff up here that I think if you're in primary care, I would develop yourself a little asthma kit. The drug reps will give you samples and examples of things, demonstrator devices and that kind of thing. Collect those things as you're going through in other specialties as well. I mean, collect those things as your little toolkit because it helps tremendously to be able to show them. Questions?
Thank you.
Thank you.